All right, let's continue now with our lymphatic system and try to get you to appreciate what it does for you every second that you exist, and you don't have to think about it. So we're continuing with the lymphatic and the thymus. Your thymus gland was largest when you were very young. Largest when young, and then becomes greatly reduced in size. As an adult. Yet it's still producing T cells. We've said many times, but since we repeat, the thymus is located on your great vessels of the heart. So now you know that that would be then your pulmonary trunk, right? And ascending aorta. We learned that the thymus receives T cells and gives them an antigen marker, gives lymphocytes, antigen marker, which will be our T cell. The thymus consists of two lobes. It's bilobed. And I think that is enough for an introduction to the thymus. Then we have the tonsils. How many have had your tonsils removed? She really did. All of them. Well, just a few, when they all sit over on this side of the room. Who knows why? But when we were little, everyone had tonsils. As soon as they got inflamed, you had them out. They knew that much about them. They thought it was bad to have them reacting to pathogens. So we've learned a lot. Tonsils, then they're masses of lymphocytes. And they are rimmed closely to the beginning of your respiratory and digestive systems. So they form a, we'll just put a rim at beginning of respiratory and digestive system. So you can appreciate that, why they get inflamed when you're little, getting unwanted quantities coming in through these open passages to the outside. We need to fight them. So the tonsils do not filter lymph like the other lymphatic tissue we've talked about, not filter lymph. They just produce lymphocytes. And since they're right beneath the surface of the mouth, they will have some stratified squamous epithelium covering them, but only some, not the whole mass of tissue. So you can always identify them in your lab when you're asked what kind of lymphatic tissue is it. If you see stratified squamous, you know immediately your tissue is a tonsil. Now there are tonsils, 3 main groups of tonsils. So we'll have palatine tonsils. There'll be 2 of them. And they are in the posterior oral cavity. Posterior oral cavity. There are lingual tonsils. Lingual tonsils, 2 of them. Where are they going to be? What's lingual? Tongue. So they're at the base of the tongue. This tongue curves around, base of tongue. And then we have 1 pharyngeal tonsil. Pharyngeal. What did we used to call pharyngeal tonsils? Ever heard the term adenoids? Never. No. Well, we had tonsils and adenoids out. But since we won't introduce it, since they don't call it that anymore. Pharyngeal 1, and this will be up in your nasopharynx. No, you can appreciate when they have to take that one out. That's not quite as easy as these 2. So that gives you an idea of your tonsils and why you have them, where you have them. And then we have Peyer's patches, which we mentioned previously. And Peyer's patches, again, you can try to figure out why we have them. We've mentioned that. We showed a slide last time, so you've seen how abundant they are. They're masses of lymphocytes in the ileum. Now, how does this ileum differ from the ileum of your pelvic cavity? Pardon? How does it spell? There's no, with your pelvic cavity, there's an I. That's our pelvis. This is it's the last part of your small intestine, right? That's what he said, but I couldn't hear him. That's okay. I heard you now. All right. So this is just before you go into the large intestine, the ileum. Now, why do you want all those lymphocytes there? Something for you to think about. Yes? I think that's a very good reason, to control the bacteria. There's lots of bacteria and more of it in the large intestine, and not allowing it to come up into the small intestine. Makes good sense. All right, then let's see. Will that finish us with our lymphatic system? No, we want to just say a few words about lymph vessels again to make it clear how they differ from blood vessels. We know that blood vessels are coming from the heart, going back to the heart. So if these were blood vessels, we're going from the heart out to arteries, out to arterioles, just reviewing, out to capillaries, and from capillaries then back to venules, back to veins, and back to the heart. Now with lymph vessels, we start with lymph capillaries. And we go to lymph veins. And we go to lymph ducts. And the lymph ducts then go into the blood vessels, specifically the internal jugular, and subclavian veins. So quite different. We have no heart, we have no arteries, no arterioles, but we start with blind capillaries. And frequently I think the hand makes a good picture. These are blind capillaries. They don't have the circulatory coming into them, all right? If you want to illustrate capillaries, lymph veins, lymph ducts, back into the blood vessels. So that gives you, what lymph ducts did we mention? A big one coming up from the abdominal cavity, up into the thorax, emptying into the jugular, internal jugular at the base of the neck. What did we call it? What cavity is this? Thoracic. What do we call the duct? Thoracic duct. Yes. So you have the thoracic duct is one of these. No, as a graduate student, we had to learn a lot about that thoracic duct. They were studying fat uptake. So you inject radioactive fat into the stomach and let it go down into the intestine, and then it gets absorbed into the thoracic duct, and then you pick it up here at the neck. You collect the lymph to see the rate of flow of fat absorption. I mean, very neat experiments. So we had thoracic ducts for lymph ducts, and we have the right lymphatic duct. So two ways in which we get back into the blood vessels from these two ducts. So now let's go to a brand new system. Let's go on to our respiratory system. The respiratory system comes under the term, we can speak of the science of otorhinolaryngology. So quite a mouthful, right? With our other systems, cardiology. Here we've got otorhinolaryngology. So how do we separate this? Oto is what? Ear. Rhino is what? Nose, good. And laryngology, throat. Ear, nose, and throat. So it goes under this category. The respiratory system is very closely related to the cardiovascular system. Respiratory and cardiovascular systems they're related structurally and functionally. So, in what ways? Well, we've already seen them as we studied the heart and its vessels going to the lungs and back again. The people in the field have divided this into external respiration and internal respiration, showing the integration of the respiratory system with the cardiovascular. So let's put, for example, external respiration. This will be at the level of what are called the alveoli of the lungs. Alveoli of lungs this is where the air is coming into the alveoli. And it has to go into the blood vascular system. Namely, capillaries. So the exchange of gases for external respiration of your O2 and CO2 is in the alveoli of lungs with the capillaries. This was air, this was blood. Close correlation. Then we have internal respiration, which takes place between the blood capillaries and the tissue cells. Internal respiration this will be blood capillaries now. With tissue cells, whether it be liver, kidney, whatever. So they do break up the difference between external and internal at these two levels. So now what we'd like to do is follow the constituents of our respiratory system. You wonder why you just can't have a plexus close to the skin and the air get right into your blood. Look at all the adaptations we have to make to get blood in through the nose and down into the alveoli of the lungs. Let's begin then with the nose. We go from the nose to the nasal cavity. From the nasal cavity to the nasopharynx. From the nasal pharynx to the oral pharynx. from the oral pharynx to the larynx, from the larynx to the trachea, from the trachea to the bronchi, from the bronchi to the bronchioles, and here we'll have terminal bronchioles, terminal bronchioles. We'll go to respiratory bronchioles, and where do respiratory bronchioles go? To the alveoli, correct. So there must be reasons for air to have to travel through all of these various units before we get exchange of gases. So then let's go back and look at the function of the nose and start with it. Three things we can say right off. One, that it has to clean the air. Two, it has to moisten the air. And three is what? Warm the air, right. So in order to do all of this, we have to have a very special type of epithelium. I mean, you've had simple squamous epithelium, stratified squamous. This is pseudostratified, columnar ciliated epithelium with goblet cells. Quite a complex epithelium. So the epithelium, which is designed to help us do this, is pseudostratified. Columnar ciliated epithelium with goblet cells. The most complex epithelium you're going to encounter. What does pseudo mean? False. You've learned that before. Pseudo-unipolar cell. So what's pseudo-stratified mean? If I have a basement membrane here, I'll have stratified epithelium in your skin, stratified, many layers. That's stratified. Only one layer touches the basement membrane. Pseudo-stratified, they look stratified, but they're not. With pseudo-stratified, they all touch the basement membrane. I don't know if we have our basement membrane. And we said it's going to be columnar, so we'll have a columnar cell here. That's perfectly fine. But here I may have another cell that comes around like this, making it look stratified, but it's not. It's pseudostratified. Another one here. So it looks like you've got these layers, but each one of them will come down somehow and touch the basement membrane. I don't know why, it's just the way it is, but it explains it to you. Then they'll have cilia on them. These are pseudostratified. Columnar cells. And what do we need to add? We need to add goblet cells to give us our mucus. So we'll find that goblet cells are sort of interspersed in here. A goblet cell. It's a mucus cell. And it secretes mucus. Why do I spell this out so carefully? Because the spelling of the name of mucus, when it's an adjective here, is different from the mucus that's secreted. You see, this is M-U-C-O-U-S, this is just M-U-C-U-S. So now, let's see how these function. Let's take our cilia first. As we saw, all the cells have cilia, and the cilia is beating posteriorly towards the nasopharynx. So all the chalk dust that I'm getting in my nasal cavity now is being picked up by the cilia and going back to my nasal. It's not coming this way, right? So the cilia will convey, we'll just put dust, dirt, whatever you like, toward nasopharynx. So they're cleaning the air. Now, to moisten the air, we need our goblet cells. They're secreting mucus. How much nasal mucus do the goblet cells produce each day? Isn't that amazing? 500 cc's. One lecture when I gave this, I didn't know somebody from the Rolling Stones magazine was in the audience. And the next issue said that the Cal students are taught how much nasal mucus they form each day. So they thought that was rather unusual. So secreting mucus, 500 cc's per 24 hours. That's a lot. So aren't you glad that it goes out through your nasal pharynx rather than out through the other direction? We're so self-conscious if we get one little drip of nasal mucus coming out the nose, aren't we? And you tell the other person, hey, you got something coming out your nose. Oh, gosh. I mean, whereas you're really pouring out 500 cc's the other way. So this mucus will go into your nasopharynx. and it will go down. We'll see if all the solutions and everything where they're finally going to be reabsorbed, because you're not going to get rid of all of this. Then we need to warm the air. So we need a venous sinus. And the venous sinuses are beneath the epithelium that line the nasal cavity. Beneath epithelium which lines nasal cavity. And their function then, is to warm the air. So all these adaptations to help prepare the air for continuing on down. These are within our functions of the nose. So other functions of the nose give resonance to our voice. All you have to do is turn to the person sitting next to you, hold your nose and talk, and you sound entirely different, right? So resonance to the voice is another function of nose. As we continue, and then it gives you your hereditary signature. You often wonder this little bump out here. You look at the parents, you say, you have a hereditary signature, like your parents. These are functions of nose. And it provides a living for our plastic surgeons, right? Rhinoplasty. So we'll put survival. They do more than survive. But it is interesting, the psychology of noses. It's a whole field in itself, right? Everybody identifies with his nose, either likes it or doesn't like it. You could have, it's just like hair. We could have whole classes on hair and how people look at hair. The psychology of noses, another function. I've not seen a class on it, but we know that it would be available if we stopped to think about it. All right, let's see if we've got all your functions here. No, one more. Very important function. It houses the olfactory nerves, right, up at the roof. Olfactory nerves. Now let's look at its structure. How is it built to do all of this? You ever thought so much about your nose before? Right there in front of you all day long? No? Structure. Well, first we have to bring in air. So we have what are called external nares. External nares. What's another term for nares? Yes, nostrils. And our internal nares will be back here, much broader. And we'll have our we'll do it this way. Nasopharynx back here. And now we can begin to look at the boundaries. So the roof will be what bone is going to be the most anterior part of the roof. The cribriform is the structure within what bone? The ethmoid. Good for you. So 2 will be the ethmoid in the rear, in the roof, and 3 will be the what? What's just behind the ethmoid? Ooh, no, we're going to run into palatine down here in the floor. We're up in the roof. Pardon? Sphenoid, good for you. So then in the floor, what will we have anterior? No, that's posterior. You're getting close. We want anterior. Pardon? No? Maxilla, sure. 4 is the maxillary bone. Now, what is posterior in the floor? The palatine. If you say it long enough, we'll come to it. Right. Palatine, right. So now we're at the palatine. There are actually 2 of these, right? 2 maxillaries, 2 palatines. And the palatine and the maxillary make up what's called the hard palate. Hard palate. So posterior to the palatine will be the soft palate. So in pink here, we've got 5, which is the soft palate. And it consists then of mucous membrane and muscle. Soft palate, mucous membrane and muscle. And this little projection of muscle and mucous membrane, which you see when you look in the mirror, when you brush your teeth at the very posterior aspect of your oral cavity, is called what? The uvula. We'll just put 6 here, and 6 equals our uvula. What does uvula mean? Grape. Look like a grape back there to somebody? And why do you have that protrusion back there? What's its function? Let's say we have our tongue here. Coming back. So when you swallow, this uvula comes up and blocks substances from entering the nasopharynx. So it has a very important function. Uvula blocks entrance to nasopharynx. Has anybody ever swallowed and had something go up into your nasopharynx? It really hurts, doesn't it? Yes, no. When we were kids and we were helping in the pick grapes in the war, when all the fellows were away, they brought in all the Los Angeles girls to pick grapes, but we had to take salt pills. They gave you a salt pill, and then you had to bend over the drinking fountain and swallow it. Guess where that pill would frequently go? Right up into your nasopharynx. You had to wait for it to dissolve, and it really burns. So when you take your pills, always stand up. All right? Good lesson. All right. Soft palate. Why'd they give? Because we were sweating so much. We were losing so much salt. It was 125 in the sun. This was down in Bakersfield. And we loved it because we wanted to get tan. You can see. We survived, but that's life. But we helped the war effort, and that's what they needed. We got all the grapes picked, so they got shipped where they were supposed to go. That was the purpose. All right, let's get back now to our bony structure of the nose. We've done the roof. We've done the floor. We want to do the medial septum. The medial septum. Medial septum. My goodness. Is it time? All right. What forms our medial septum? It's going to be dividing our right and left nasal cavity. Divides right and left nasal cavity. So we'll have a bone called the vomer. We'll have the perpendicular plate of the ethmoid. And we'll have hyaline cartilage. So our septum consists of one, the vomer. What does vomer mean? Plow. Have you ever seen a plow with a sharp blade that goes through the earth? This was the shape of a plow. Vomer. Two, this was perpendicular plate of ethmoid. Perpendicular plate of ethmoid. And three will be cartilage. Now, who can tell me what kind of cartilage? Hyaline. Good for you. You know it's not elastic, and you know it's not fibrous, so everything else has to be hyaline, right? You're learning. Great. This is hyaline cartilage. The process of elimination is part of learning. All right, let's just take the lateral wall then, because we've had medial wall, we've had roof and floor. Lateral wall has its own personality. We're going to have concha. And right now, in this direction, we're going to put them linearly. But what they really are curved like a shell. These big conchs that you find on the beaches of Hawaii or out in the Pacific, they curve. So we'll have a superior conch a middle and an inferior. And under the curve, if we have coming from the side, the conch would look like this. This is the lateral wall. This is superior, middle, and inferior. And the area underneath the conch is called a meatus. The middle meatus, which would be this one, receives secretion from the maxillary and frontal sinus. The maxillary and frontal sinuses drain into the middle meatus. What drains into the inferior meatus? Notice when you cry and your tears are pouring out, your nose runs. It's tears. Your inferior meatus you get tears. How do they get there? Here's your eye, here's your eye. On the lateral superior aspect of your eyes, you have your tear glands. Called lacrimal glands. This would be a lacrimal gland. And those tears are designed to moisten your eye and clean your eye. They're going across in this direction, your tears. And at the medial aspect of your orbit here, you have a duct. This is called the nasolacrimal duct. And so the tears then are going to go down and they're going to come out here in your inferior meatus. So that's how your nose runs. They're really tears. It's not nasal mucus. It's tear. I guess we will have to wait for our slides then. Thank you. I'm sorry. We'll have to do those next time.